perf. All right. How many of you have heard the term spondylopathy before, or maybe have some level of familiarity with what a spondylopathy is? Okay. Justine, what is a spondylopathy?
It's like a fracture of the spinous process, or like partial fracture.
Okay, yeah, so that's definitely one type of spondylopathy. So we call that, so another name for that would obviously be a pars fracture, or kind of a fracture of the pars articularis, which we'll talk about when we get to the lumbar spine. But okay, first and foremost, right, the spondylopathy, if we just take the anatomical terms and put them together, a spondylopathy is essentially a disease process involving the vertebrae, right? And there are a lot of different types of spondylopathies that you guys are going to see throughout your career, right? And so these can be congenital, right? They can be something that people are born with, right? They can also be changes that are essentially degenerative over time, right? They can happen due to repetitive microtrauma. Now, Justine, to your point, like you just said, right? This is definitely a lot more common, at least the spondylopathies that result from repetitive microtrauma, right, are a lot more common in athletic populations, generally because of forced hyperextension of the lumbar spine, also the cervical spine, right? And so not uncommon to see those repetitive microtrauma cases in the population that we see every day, right? So here's a tricky thing about spondylopathies. Okay, spondylopathies are they're kind of bananas in the sense that if we have a spondylopathy, sorry for the noise, by the way, stop chewing on your ball, please. It's noisy. Yeah, go over there, buddy. So the spondylopathy, right? If we have them, this can actually result in other pathologies around the vertebrae, like stenosis, right? Narrowing of the intervertebral foramen, right? Or the central canal, right? Through which the spinal cord passes, right? Because of spondylopathies as well, we can have radiculopathy, right? Which is pathology involving a nerve root, right? That generally is encroached upon by a bony element and or like disc material, right? Sometimes these can be traumatic. And then we have the cases of obviously myelopathy, which is a compression at the level of the spinal cord, all right? And so I'll give you guys a second on this. It looks like you're writing. So I will give you guys a hot minute. And this is going to be on Moodle, so don't worry, but I'll give you guys a sec. All right, how are we doing here? Are we good on this, or do you need a little bit more time? We're good? Sweet. Okay, what's an example? All right, so let's take a look at this for a second. Spondylopathies, all right? Ultimately, right, we can see that these spondylopathies can have, different far-reaching consequences. And so we need to pay attention, right, to the essentially where, right, in our three canal system that we're having this, essentially this spondylopathy. Okay, so let's take a look at a couple of examples here. All right, so this is actually an individual that has some spondylopathy here at C5, C6, and then C6, C7. So here we go. If we take a look, right, we can definitely see C1, 2, 3, 4, right, 5, 6, and 7. All right, now here's the thing. Take a look at the vertebral body, so the anterior column in this patient. Look at the, and you guys probably obviously can see this, but take a look at, and I'll do a little bit of drawing here. Take a look at this beautiful disc height here between 2 and 3, between 3 and 4, between 4 and 5. Okay. And then take a look at the difference in the disc height here between 5 and 6, and 6 and 7. Okay. Do you guys see the difference there? It's vastly different. So this individual, this patient, has lost quite a bit of disc height, right? And if we take a look here, so if you take a look, okay, at this X-ray back here, okay, at the posterior aspect of the spinal canal, you actually see these. I don't like so these little dark holes back here. Okay, this is actually the intervertebral foramen. Okay, where the peripheral nerve actually passes through, and you can actually also see, okay, and this guy actually has multi-level stenosis actually at the foramen as well. But if you look down here at between 5 and 6 and 6 and 7, okay, you can actually see how he's almost completely and totally lost that foramen on X-ray. Okay, so he definitely has some stenosis here, obviously at 6, 7, and then also at 5, 6. Okay, who remembers, by the way, from your anatomy class, where do the nerve roots, okay, where do the nerve roots come off of the cervical spine? Do they come off of the cervical spine above the vertebrae or below the vertebrae? Who remembers?
I think below.
Okay, all right. Okay, here's the crazy thing. Okay, let me frame the question this way, because Bella, I love the fact that you stuck your neck out there and participated. I love it. Okay, here's the thing. We have a C8 nerve root, so why don't we have a C8 vertebrae? I'm sorry, you guys are both muted if you're trying to talk.
Well, it has to be below, right?
Okay, great question. So here's the deal, right? If we remember, okay, let's take a look here. So here's this big pop right here. Here's 7, right? So here's the deal, right? Remember that in the cervical spine, my nerve roots always come off above the level of the vertebrae. Okay, so someone who has, for example, a C8 radiculopathy will actually present with symptoms, right, above the level of the vertebrae. Okay, that's why someone with, maybe some tenderness at C7T1, right, will actually have what we call potentially a C8 radic, particularly if they have symptoms into the pinky, right? So if we look at the anatomical course of these nerve roots, all of them exit above the vertebrae to which they're referenced, okay? And so C8 exits above T1, right, but below C7, okay? And then once we hit T1, T1 comes out at the bottom of the vertebrae, and then 2, 3, 4, on down through 12, okay? All right, so obviously, okay, narrowing between C7 and T1 here would indicate, right, a C8 could indicate a C or cause a C8 radic, okay, a C8 radiculopathy, okay? Narrowing obviously between 6 and 7 could cause a C7 radic because C7 comes off above, right, the vertebrae itself. Okay, cool. Any questions about that? You guys are free to fact check me on that, but I promise you it's true. Okay, I know that seems really kind of strange, but let me clear these joins. Clear. All right. Okay, what's an example? Okay, question. Let's say that this stenosis, right, or this spondylopathy, let's say that it causes encroachment, right, at the central canal, right? So ultimately, here's my vertebrae, and I have some stenosis or maybe even a disc herniation that's occupying the foramen, right? That's inside of the foramen, occupying the foramen, excuse me, and is touching the cord, okay? Obviously, then, if that's the case, my symptoms are going to generally present how?
Myelopathically.
Myelopathically, okay. And if I have a myelopathy, are my symptoms generally going to be unilateral or bilateral?
Bilateral.
Could be bilateral, absolutely. Okay, cool, cool. All right, cool. And so obviously then, narrowing at the intervertebral foramen, obviously it's going to affect the peripheral nerve at the level at which it exits, okay? And it can obviously cause unilateral symptoms. Okay, what's an example of a congenital spondylopathy? We're going to see a couple more examples of this as we move on, but this is really common. And guys, this is crazy important for you to know about, right? Because this can definitely be extremely relevant, particularly if you're working in a high school. Okay, Klippel-Feil syndrome. What? Why do we care about this, Wade? Here's why we care about this. Okay, Klippel-Feil. This is a congenital spondylopathy, okay, that results from a congenital fusion, right, of the anterior column and or the vertebral body, right? So look at this little guy here, okay? So let's take a look here. So take a look at his flexion extension films here on this X-ray. See how he has a nice, awesome vertebral body here at 7, 6, 5. Oh my gosh, what happened at 4 and 3? Look right here. Okay, you see how 4 and 3 are essentially fused together. Okay, this is Klippel-Feil syndrome. Okay, now ultimately, Klippel-Feil syndrome, obviously, because it results in that congenital fusion of the vertebrae anteriorly, this, right, is a definite concern, excuse me, particularly when talking about people's eligibility for participation in traditional athletics, right? So here's a question for you guys. Okay, let me remove my little, there we go. All right, here's a question for you guys. Let's say that you had a patient come into your athletic training room, maybe during physicals, all right? And you ask them, you know, do you have a history of anything like any neck pain, neck problems? And they said, yeah, I was diagnosed with Klippel-Feil as a child. Okay. So what type of as far as participation in athletics, what can this person do and what can they not do? What do you think?
Would it be only non-contact sports?
Okay, non-contact sports. Yes, absolutely. And why, Bella? Why only non-contact sports?
I mean, I just assume it puts them at more risk for severe injury.
Absolutely, right? Definitely more risk for severe injury. But here's the other thing, right? In Klippel-Feil, because we have this fused segment at the anterior body, what starts to happen with these people is that they actually can develop hypermobility at the adjacent segments, right? So between essentially, 5 and 6 or 6 and 7. So because they don't have, right, motion at the motion segment that's fused, in order to complete flexion and extension or to be able to flex and extend, they will compensate by developing more motion in adjacent segments over time. Now, because they have more motion in adjacent segments over time, if they God forbid take a blow to the head and or axially load the neck, right, that can be catastrophic for these people, more so than someone who does not have Klippel-Feil, right, who does not have this congenital abnormality, right. That can be extremely catastrophic. So obviously, being aware of this is extremely important. Another thing to note that people with Klippel-Feil will often present with, okay, is that they may also look like they have a shortened neck stature, almost kind of like they have a short neck. Okay, the reason for that is, why do you think that's the case, guys? I mean, this is kind of a question, right? Why would that be the case? Look at what we know about the fusion at the body here. What do they not have between the fused segment that they have between the others that contributes height to the cervical spine? What do they have? Go ahead.
A disc.
Exactly, yeah, exactly, Maddie. Absolutely, right? So, yeah, You're absolutely correct, right? So because they're missing disc height, right? Because they're missing that disc height, they will essentially lack height right at the cervical spine, and it will actually make their neck look shorter than it should. Other things that you may also see, excuse me, in these individuals is essentially the presence of what we call a low hairline. They may have a hairline that kind of looks that extends a little kind of lower down on the back of the head. I know it sounds really random, right? But the other thing that you may also see with people with clipple file is actually dental abnormalities as well, right? So things to look out for in kids with clipple file, right? Yeah. So if you guys know about this and you're aware of it, you could save someone's life. No joke, right? Because very often parents aren't aware, right, that their child has this unless they've been x-rayed for it and they know about it. So generally, this can come as a surprise to a lot of people, particularly parents. Okay, cool. Okay, let's talk about stenosis. Doggone it. Cervical stenosis, clear out. Thank you. Okay, so obviously stenosis, right? We've heard this term before. Okay, this is obviously narrowing of the intravertebral foramen. All right, and that can happen obviously either centrally, right, at the central canal, or right peripherally at the intravertebral foramen, where the nerve root exits. One thing that's really important to note, though, with stenosis is that these patients will often present with neck pain that's worsened by axial loading, right? And they'll have limited range of motion, deflection, extension. So if you guys go back and think about what we did yesterday in class, right? What tests, generally if someone has stenosis, which test, I'm sorry, which tests are we going to do on these people that will potentially be obviously very painful for them, and or will also generate neurological symptoms into the upper extremities? What tests might we do on these people that are going to make them symptomatic?
Is it the Spurlings and axial compression?
Absolutely, Josh. Absolutely. Okay. Yeah. So obviously they're not going to respond well to axial loads on the spine. So a long time ago, we had this happen in a football player many years ago. But we had a young man come in to see us with progressive neurological symptoms. He was a running back, right? And he had numbness and tingling in both hands, right? And this started kind of early during 2 days, and just gradually kept getting worse throughout the season, right? And so lo and behold, as this continued to get worse and he started to display some weakness, we sent him in for x-rays. We sent him in for x-rays, and he actually had central canal stenosis at the age of 20, right? He was 20 years old, had central canal stenosis, and actually continued playing football, right, against recommendations, obviously, from physicians and athletic trainers. Continued playing football, but was able to actually complete his career. But yeah, not something that you see a lot in younger populations, particularly stenosis at the central canal and or the foramen that's not caused by like a disc herniation, right? So yeah, so ultimately, as we know and as we've learned, and you guys know by now, right, depending on where the stenosis occurs is gonna provide a lot of information for us as to how the symptoms present, whether bilateral, whether unilateral, whether potential myelopathic presentations, or radicular. Okay. All righty.
I have a question.
Yeah, what's up?
How do you legally let a person play like that?
So that's a good question. So ultimately, this, and I don't remember honestly all the full details of the case because I was not in charge at that point. My boss at the time was in charge of this case. And so ultimately, this young man had stenosis, but he and his family, from what I remember, made the informed decision to continue playing despite the risks. And there was documentation on file stating that they had chosen to do so, and they essentially waived the university of any liability in the event that he was catastrophically injured or harmed, right? Which is quite frankly, that's a very bold choice to make. But, and you guys will see that too. Like there are people, like with some of the concussion laws in different states, there have actually been cases of parents and student athletes suing school boards, doctors, so on and so forth, because they've been withheld from competition and actually sued to be able to play. Like those things happen. It's bonkers that those things take place, but they do. Yeah, it's crazy. And that's what's one of the reasons, guys, why working in traditional settings sometimes and seeing, and it's not that, and sorry, this is kind of a sidebar, but and it's not the fact that parents and coaches and people shouldn't want the best for their kids and want them to succeed. But at the end of the day, it's a damn game, crying out loud, and it's like, it's, pardon my language, but I had several experiences throughout my career, and it's hard because it's a game at the end of the day, and less than 1% of the people that play in the NCAA are actually going to go on to play in the NFL professionally. And that's a whole nother discussion, but it's a game, right? And your child has to worry about having a job and graduating and leading a life, right? Anyway, I'm done. Let's move on because that's a whole nother thing we could get into. All right, friends. Actually, yeah, we just talked about that. Sorry, I got sidetracked. Next one. Okay. What happens? Okay. What happens when? Sorry. When we actually have spondylopathy to the point where we have bony breakdown and we actually start to notice instability of one segment on another. Okay, then, excuse me, our descriptor for the pathology, for the pathology, words are hard, sorry, changes. Okay, we have, so obviously we have spondylolysis, but when we start to see migration of one segment on another, okay, we call this spondylolisthesis. Okay, so we can have a cervical spondylolisthesis. These can happen in the lumbar region as well, like Justine was kind of telling us at the beginning of class. Okay, so we take a look at this here. We can see at this X-ray, we completely and totally lost, right? Not only the alignment of our facet joints. Hang on, guys, 1 second. Bingo. Okay. So we completely and totally lost the alignment of the facet joints, and you can see that we've begun to migrate anteriorly, right? So, okay, I love this. Who can tell me, right, what components of this individual's X-ray are still relatively well preserved? If you look at the anterior body here, what about this X-ray is still in relatively good condition? He's got what?
Discs.
He's got disc. That's a start, right? Yay, right? So he still has relatively well preserved disc height still, right? So that's good for him. However, this person also has, right, obviously this anterior listhesis of the vertebrae, right? So obviously of 6 on 7, 5 on 6, and 4 on 5 that we can see here. Okay. Is this making sense, guys, or am I just like flying through this way too fast? We're okay? Okay, cool. All right, beautiful. Okay, now here's the deal. What do you think, if you think about spondylolisthesis, particularly this multi-level spondylolisthesis, what type of symptoms could this individual present with to you if they had this going on, particularly with this anterior listhesis of the vertebrae?
Could it be like difficulty swallowing and
Okay, could be, yeah. Oops, sorry, Josh, were you still talking, buddy? Or no?
No, I lost my train of thought. So
It's okay. It's okay. So, and let me see if I can kind of help you get back on track here. So, difficulty swallowing, right? Uh, Obviously, because of the anterior, obviously translution of the vertebrae, what else might we see based on changes in essentially foraminal diameter? Any thoughts? So obviously, if he's translated anteriorly, the diameter of the foramen has changed. It's gotten smaller, right? So what are we likely to see potentially?
Nerve or spinal cord compression.
Okay, yeah, okay, which generally is going to result in symptoms, right? Numbness, tingling, weakness into the extremities, either bilateral or unilateral, depending on obviously the side of the lesion. Love it. Okay, cool. Okay, now here's the deal. So what we're seeing in this picture, guys, this is obviously, what we call spondylolisthesis or anterior listhesis. But there are also situations in which the vertebrae can actually migrate posteriorly. Whoops. Yeah, this is my little arrow. It can actually migrate posteriorly. That is actually called retrolisthesis. Okay, that can also happen. So we can have one vertebrae that migrates posteriorly on another. That's called retrolisthesis. So we have anterior listhesis and we have retrolisthesis. Okay, so things to be aware of. Okay, beautiful. All right, I'm going to show you guys one more pathology with the time we have left, and this is particularly if you guys end up working in a clinic. You won't see this a ton, but you will see it. This next one, get rid of my drawings here. Okay, this next one is abbreviated. It's called DISH. Okay, check this out. It's bananas. Whoopsie. Okay, look at this. So this is an individual with DISH. Okay, so ultimately this is diffuse idiopathic skeletal hyperostosis. Okay, we abbreviate that as DISH because that's a really, really long thing to say. Okay, now ultimately what you're going to see here, if you look down at the bottom, all right, if you look down at the bottom, you can see how this person has essentially what we call these bridging syndesmophytes. Okay, and don't worry, I'll post this for you guys, and I'll write that down. Okay, they have these bridging syndesmophytes. I'll do a circle. Okay, check it out. So this is actually this area right down here. You see where my circle is? Okay, you can see how right here between essentially 6 and 7, how he's actually starting to develop what we call a bridging syndesmophyte, where ultimately that's already happened here, and these vertebrae have actually completely and totally fused together anteriorly. All right, but down here at the bottom, he's developed a little bit of a spur, right? And so then he has these bridging syndesmophytes here, okay, right down here between 6 and 7. Ultimately, what will happen is these will actually completely close together and fuse, right? And the anterior column of this poor man's spinal canal will look like this. Okay, so that's just rough. That's a bad day. Okay, what do we think? By the way, let's think about our exam for a second. What do we think this individual's range of motion is going to look like on exam? Will he be able to flex and extend? No, he's going to have really, really poopy flexion and extension. Okay, definitely not going to be there. Going to be extremely limited, if not, there present at all. Okay, now, luckily for him, obviously he also has multi-level, obviously, stenosis actually posteriorly as well, because he's completely and totally lost his foramen. So this individual will likely, there's not really a lot that you can do for these people surgically. You can try to manage symptoms with injections, and so, but ultimately that's really all you can do. So that is our introduction, guys, into spondylopathies. Okay, I know that was kind of a lot, and we kind of zipped through a bunch of information quickly. We can definitely review that if you want to. All right. But yeah, okay, so that's kind of where we started today, and so I hope that that makes sense. Thanks for putting up with me and kind of bearing with me kind of through this one. This was kind of a lot of different and varied information, but hope you guys have a great day. All right, and I'll see you in person tomorrow. Like I said, we may, I'm not entirely sure if our prospective student will be observing our class and or Tech 1. It might be Tech 1, but I'll have to check. So we may have a guest. So we have to be on our best behavior, friends. Not that you're not. You guys are always well behaved, kind of ish. Okay, but you guys have a great day. Okay, and I will see you tomorrow. Okay.
Thanks.
Bye, guys. Josh.